retrospective study by Dr. Kora.
Good afternoon, everyone. Today my topic is topical versus intravenous tranexamic acid in reducing blood loss after bilateral TKA, a prospective study. A total knee replacement is a cost-effective and efficacious treatment modality for severe OA knees. However, TKA can be associated with significant blood loss, with 10 to 38% of patients requiring allogenic blood transfusion perioperatively. Serious complications associated with blood transfusion include viral infections, transfusion-related reactions, and fluid overload. Furthermore, transfusions significantly increase the length of hospital stay and hospital cost. The risk and cost of blood transfusion, together with challenges in obtaining sufficient labeled blood products, have generated interest in blood-conserving strategies such as hypotensive anesthesia, intraoperative blood salvage, use of erythropoietin, and antifibrinolytic agents. In this study, we used tranexamic acid as an antifibrinolytic agent that competitively inhibits the plasminogen, which converts to plasmin, that enzyme that degrades the fibrin clots. Aim of our study is, in simultaneous bilateral TKR, is there a significant difference in efficacy between topical tranexamic acid and intravenous tranexamic acid? Material methods. The study was approved by the ethics committee at our hospital, and all the patients gave the written informed consent. We enrolled 70 patients with either rheumatoid arthritis or osteoarthritis who were to have a bilateral cemented total knee arthroplasty. The exclusion criteria were a known allergic to tranexamic acid, preoperative hepatic or renal dysfunction, serious cardiac or respiratory diseases, congenital or acquired coagulopathy, and a history of thromboembolic disease. Patients were randomized. Patients in group A received intravenous tranexamic acid 10 mg per kg in 20 ml normal saline as a bolus dose prior to skin incision, then by infusion of 5 mg per kg per hour in the form of 500 mg of tranexamic acid in 250 ml with a rate of 80 ml per hour until the end of surgery. Group B, prior to wound closure, 20 ml of normal saline is mixed with 1.5 grams of tranexamic acid and was poured into the surgical field and left for 5 to 7 minutes before inserting drain and the wound closure. Outcomes measured by postoperative bleeding, surgical drains immediate and 24-hour postoperatively, hemoglobin concentration, hematocrit immediate and 24-hour postoperatively, number of patients requiring blood transfusion after 24 hours postoperatively. Results: mean total blood loss was significantly lower in the topical TXA group compared to IV tranexamic group. The postoperative drainage volume was significantly lower in topical, which is right side 168 and left side 134 plus or minus 67 ml when compared to IV tranexamic group. Mean drop in the HB level was smaller in the topical TXA group, which is 1.60 plus or minus 0.68 when compared to the IV tranexamic group, which is more than 2. The incidence of transfusion was significantly lower in the topical tranexamic group. You have no blood transfusions in topical tranexamic group, whereas in IV tranexamic group, we had 7 blood transfusions, each receiving 1 unit of PRBC, and no cases of DVT or pulmonary abundance were recorded in either group. This is a picture showing before getting down the tourniquet and after getting down the tourniquet. We wash the wound with the pulsatile lavage and hemostasis is achieved, and we add 1.5 grams of tranexamic acid in 20 ml of saline in a syringe, and we pour it into the surgical site and wait for 5 to 7 minutes before closure. Conclusion: in simultaneous bilateral total knee arthroplasty, topical administration of tranexamic acid demonstrated significantly reduced total and postoperative blood loss, as well as transfusion required when compared to intravenous administration. The results of this study suggest that topical tranexamic may be more effective than intravenous administration in reducing blood loss in cases of simultaneous bilateral total knee arthroplasty. This tranexamic at higher concentration also acts directly to inhibit plasmin activity. The trauma of surgery activates fibrinolysis by promoting the release of tissue plasmin activator. Although the body naturally inhibits fibrinolysis by 24 hours after surgery, antifibrinolytic agents such as TXA can block the activation of plasminogen to plasmin earlier and thereby decreasing the perioperative blood loss. It can be given as perioperative dose before tourniquet inflation, intraoperative dose before deflation of the tourniquet, and postoperative dose 3 hours after surgery, and various permutation combining these 3 doses. Is when given intravenously as a wide distribution throughout the extracellular and intercostal compartment. Its biological half-life is 3 hours in joint fluid, and 90% of it is eliminated within 24 hours by glomerular filtration. Meta-analysis shows intravenous tranexamic effectively reduces the perioperative blood loss and incidence of blood transfusion after TKR without increasing the risk of thromboembolic events. Although the body, however, many common medical conditions include renal impairment, cardiovascular diseases, cerebrovascular condition, and the concurrent presence of hormonal treatment may preclude the use of intravenous tranexamic acid at the time of surgery. Giving intra-articular tranexamic acid during TKR has only started to gain popularity in recent years. It can be given as a topical wash or into the knee joint after wound closure via the drain. Compared to intravenous administration, advocates the intra-articular transmission believe the benefits include ease of the administration, ability to achieve maximum concentration on the bleeding site, and minimal systemic absorption. Furthermore, the use of tourniquet and TICA results in negligible intraoperative blood loss, but notable postoperative blood loss, which is the ideal scenario for using intra-articular hemostatic agents intraoperatively. These are the references. Thank you.